Dr. Mansoor, you are here. You are in the right room.
Oh, okay. I thought I'm in the wrong room because I don't see the participants for the PNT workshop here. I can see Shireen, Dr. Shireen has joined, but I don't see the other participant. Dr. Zahid is here, but Dr. Tahir Aziz Mol.
He's here also. Dr. Shamim is not here yet, but the rest of the individuals are here.
I think Dr. Ahsan, Dr. Salwa Ahsan is probably going to join later on. She has some problems actually.
So maybe kindly can we ask our presenters to have their videos on, if you agree? So you can ask.
Sure. So Dr. Zishan Khan is here.
He has assigned his backup. He's in another room, inshallah, but he will be available.
Okay. So who is going to do the moderation? Because he was supposed to do the moderation, and actually we had like everything.
Gigi, he has assigned someone. Let me ask the name. Just one more minute and we can start. Dr. Mansoor Khan, inshallah, will start at 2:05.
Sorry?
We'll just allow people to come in and,
Sure.
and then we'll start, inshallah.
If you can mention it, that just we are a little bit behind the schedule because of the technical problem with the previous session. So so how long is the delay? Like 5 minutes, 2 minutes? I didn't get it.
We'll start in the next 3 to 4 minutes maximum, inshallah.
Okay, so we can let Dr. Shireen pray Fajr as well in North Carolina.
Yes.
Okay.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam wa rahmatullah. Dr. Shireen, we apologize, but if you would like to go ahead and do your Fajr, you're more than welcome to. We'll wait for you.
No, I'm done.
Okay. Taqabbalallah, inshallah.
Were you able to see my screen when I shared it?
There were some slides up in the blue background. Yes,
yeah.
We did. Yes.
Is that clear? Okay.
That they are, just put them on the slide view. Full.
Yeah, sure. I'm just testing.
Yeah, that's all. Yes, yeah.
Okay.
Otherwise, it's visible and you're audible.
Okay, that's great. Thanks.
Thank you.
Assalamu alaikum, Dr. Shireen.
Alaikum salam wa barakatuh.
Nice to see you after a long, long time. Like 2 months, like past like 2 years. We feel each month like a year. Because we spend like 15 years together in the same institute.
It's nice to see you as well.
Did you pray Fajr?
Alhamdulillah, yes, alhamdulillah.
Okay, actually, we are a little bit behind the schedule today. And there was technical glitch in the previous sessions. So we had the after effects of that. Actually, you know, in virtual meetings, sometimes you don't go as planned and as scheduled. So
you had a meeting before that?
Yeah, we started meeting yesterday. Actually, it's 2 days meeting.
Oh, okay.
We had the health minister as a chief guest in the opening ceremony yesterday, and he gave a very nice speech. And this is the second version of the conference. Actually, we had one conference last year, and this is the second conference, actually, second edition of our conference, and it was much better than before. And there are lots of positive that we are seeing from this conference, and we see ourselves moving on forward, establishing like good clinical.
Assalamu alaikum wa rahmatullah. Dr. Zishan Khan is here, so I'll hand it over to him.
Assalamu alaikum. So are we live? We can start the workshop.
We are live, sir.
Assalamu alaikum, dear participant. On behalf of Giving Back to Pharmacy in Pakistan, I, Mohammad Zishan Khan, would like to welcome you all to workshop on establishing Pharmacy and Therapeutics Committee at your hospital in our second virtual Innovation in Pharmacy conference. Giving Back to Pharmacy in Pakistan is a volunteer group which includes pharmacy professionals from all over the globe working together to nurture the pharmacy profession in Pakistan through their experiences, skills, and knowledge. Giving Back to Pharmacy in Pakistan is an organization of volunteer pharmacists from around the world with Pakistani origin, aiming to refine the pharmacy profession in Pakistan by sharing best practices and engaging the relevant stakeholders in order to empower pharmacists for better healthcare in Pakistan. Efficient engagement of pharmacists and Pharmacy and Therapeutic Committee and Formulary Management is in line with the vision and mission of Giving Back to Pharmacy in Pakistan, and it will provide opportunities in advancing pharmacy practice in Pakistan. A little bit introduction about the PNT. The Pharmacy and Therapeutic Committee is generally the medical staff committee. It consists of physicians, pharmacists, nurses, and other healthcare workers responsible for managing the formulary system. The Pharmacy and Therapeutic Committee provides an evaluative, educational, and advisory service to medical staff and organization administration in all matters pertaining to the use of available medication. The PNT committee should be responsible for overseeing policies and procedure related to all aspects of medication used in the institution. So at the completion of this workshop, all the participants will be able to understand the role of Pharmacy and Therapeutics Committee, understand PNT structure and organization and its relationship to other hospital committee, understand the function of Pharmacy and Therapeutics Committee, including advisory responsibility, development of policies and procedure, formulary management, identification of medicine use problems, and promotion of strategies to improve medicinal use and medication safety. Discuss the importance of Pharmacy and Therapeutics Committee in promoting rational use of antibiotics, medicine, and other injections, and what are the challenges and how to overcome them. So in this workshop, there will be two presentations, 20 to 25 minutes each, followed by a panel discussion of 10 minutes each. And then in the last, we'll have conclusion and recommendation about how to establish a Pharmacy and Therapeutics Committee. So our first panelist for today's workshop is Dr. Shireen Ismail. She is a pharmacy graduate of the College of Pharmacy, the University of Alexandria, Egypt. She earned her Doctor of Pharmacy degree in 2004. Dr. Ismail is a board-certified pharmacotherapy specialist in 2009 and got a board-certified ambulatory pharmacy care in 2015. She earned her Master's of Public Health and Epidemiology in 2017 from Harvard T.H. Chan School of Public Health, Boston, Massachusetts, United States. She began her career in Egypt as a nephrology clinical pharmacist in Alexandria University Hospital for 1.5 years. Then she moved to Saudi Arabia and served as a nephrology and transplant clinical pharmacist at King Abdul Aziz Medical City, Ministry of National Guard Health Affairs, Jeddah, for almost 15 years. In that capacity, she served as a clinical pharmacy preceptor and mentor for pharmacy interns, residents, and as an adjunct clinical professor in the Department of Clinical Pharmacy at King Abdulaziz University, Jeddah. She was appointed as a coordinator of Pharmacy and Therapeutics Committee for 10 years from 2011 to 2021. And in addition to her participation as a member and coordinator of many other subcommittees to evaluate drugs for formulary addition and develop many regional and corporate drug use policies. Dr. Ismail is a clinical researcher with a specific interest in renal patients, solid organ transplant, adherence to medication, practice-based, and outcome research. She has several publications and serves as a reviewer for a few journals. She started her PhD in pharmacoepidemiology at the University of North Carolina School of Global Public Health in August 2021, and currently is working as a fellow of the Pharmacoepidemiology Center of UNC, North Carolina, United States. Thank you, Dr. Shirin, for honoring us with your presence and sharing your experience. Our second panelist is Dr. Mansoor Khan, who is currently working as a senior clinical pharmacist covering oncology, hematology, BMT at Ministry of National Guard Health Affairs, Jeddah for the last 14 years. Mansoor Khan is a graduate from Bachelor of Pharmacy from University of Punjab, Lahore in 1999. And then he completed training in clinical pharmacy from Shaukat Khanum Cancer Hospital and Research Center. After completion of his training, he started working in the same hospital as clinical pharmacist and later on as in charge of clinical pharmacy. In the meantime, he completed his master's in clinical pharmacology and therapeutics in 2005, and then he joined Ministry of National Guard Health Affairs as a clinical pharmacist in 2006. He has been working in National Guard since then. He obtained his board certification in oncology in 2010 and then got a recertification in 2017. He's a keen member of important committees in the hospital, including P&T committee, his formulary, management recommendation, and cost-effective analysis have significant cost-effective impact in Ministry of National Guard Health Affairs. He is heavily involved in teaching students, residents, and fellows in the hospital as well as in the university. He has also been involved in the clinical research and have published more than 20 papers in peer-reviewed journals. He established oncology clinical pharmacy services in Princess Noha Oncology Center and other services in the department. Thank you, Dr. Mansoor, for your presence. The two presentation by these two speakers are followed by a panel discussion, and for a panel discussion, our third panelist is Dr. Tahir Aziz Mughal. Dr. Tahir is a consultant, leading practicing pharmacist, educationist, and hospital administrator. Over the past 2 decades, he has worked in a wide variety of professional capacities in both private and public sectors. He led several projects in pharmacy, capital budgeting of hospital, including development of Oracle-based clinical decision support system. His primary interest includes the hospital pharmacy, health informatics, hospital project feasibility, and clinical pharmacy advancements. He has done his pharmacy graduation and Master of Philosophy in Pharmacy from University of Punjab, Lahore, Pakistan. He earned his Executive MBA in 2009 through University of Management Sciences, Lahore. He completed his Doctor of Philosophy from Pharmacy Department, Quaid-e-Azam University, Islamabad in 2020. He also earned several professional certificates, including Leadership in Health Program from Utrecht University, Netherlands, and Hospital Management Program from Singapore. I welcome you, Dr. Tahir, for our workshop today. Our fourth panelist today is Dr. Salwa Ehsan. Dr. Salwa is a professional pharmacist with more than 20 years of experience and expertise in hospital and clinical pharmacy setups, pharmacy informatics, computerized physician order entry system, medication safety, and quality management system of healthcare pharmacies. She is well-versed in Joint Commission of International Accreditation Standards for Hospital and Home Care and is a certified ISO 9001 lead auditor. Currently working as the Chief of Pharmacy in Shifa International Hospitals, both being JCI accredited organizations, serving on board of studies of Shifa College of Pharmaceutical Science, Shifa Tamir-e-Millat University, on editorial advisory board, National Organization of Journal of Tamir-e-Millat University. Serving as an expert Hospital Pharmacy and Policy Board by Drug Regulatory Authority Pakistan, and also serving as a member in various committees like Pharmacovigilance, critical drug shortages, clinical studies committees, and Drug Regulatory Authority of Pakistan. I welcome Dr. Salah for our workshop. Fifth panelist today is Dr. Syed Shamim Raza. Dr. Raza is Director, Service Line Chief of Pharmacy, the Aga Khan University Hospital, Karachi, Pakistan. He received his bachelor and PharmD degrees from Faculty of Pharmacy, University of Karachi. He also holds the Research and Ethics Fellowship from Johns Hopkins Bloomberg School of Public Health. He went on to complete many patient safety programs in regards to medication management and the use of Six Sigma Institute, Joint Commission International, and Electronic Health Record System Meditech. He has the expertise, leadership, training, and motivation necessary to successfully carry out the pharmacy operation with an experience of 2 decades working at academic medical centers in Karachi, Pakistan, and Nairobi, Kenya. Dr. Shamim has publication both as principal investigator and co-investigators on several projects. He is a member of Hospital Joint Staff Committee, Pharmacy and Therapeutics Committee, and Ethics Review Committee. He's a strong advocate of patient safety, staff capacity building, and innovation in hospital pharmacy operation. Our sixth and final panelist today is Dr. Zahid, Dr. Zahid, who is a patient care-oriented young pharmacist, graduate from Akhtar Saeed College of Pharmaceutical Sciences in 2016, having a diversified experience of working in Surveyed Pharma, one of the biggest chain pharmacies in Punjab, and he's a former trainee and ambulatory care pharmacist in Aga Khan Hospital, Karachi. Currently pursuing his MPhil pharmacy practice from University of Sargodha, meanwhile working under primary and secondary healthcare department, Punjab at THQ Hospital, Sabdarabad as clinical pharmacist, pharmacovigilance officer, and hospital drug inspector. I would like to thank our panelists and speaker to take out the time from their busy schedule to enlighten us on how to establish Pharmacy and Therapeutics Committee in your hospital, especially to Dr. Shireen, because she was kind enough to join us from North Carolina, US at 6 a.m. in the morning, just to share her experience with us about PNT. I would hand over this session to Dr. Shireen to start the presentation. You can go ahead and start your presentation. Dr. Shireen, over to you.
Okay, thank you. Are you able to see my slides?
Yes, Dr. Shireen, we can see your slides.
And can you hear me very well?
Yes.
Yes.
Good? Okay, excellent. Okay. So, assalamu alaikum wa rahmatullahi wa barakatuh, everyone. It's my pleasure to be with you today in one of those workshops for giving back to pharmacy. And it's a really very dear topic of experience and kind of a hot topic in pharmacy practice. And it's essential that every institution seek to have a very robust formulary management process. So I'll be sharing with you some of the experience that I had during my work as a clinical pharmacist in King Abdulaziz Medical City. And in most of the talk, I would probably be giving more of a general outline that can be implemented in any place. However, there are of course, some technical issues that have to be addressed to be, customized. So this is going to be from an institutional perspective, and we can think of it of also a multi-center or a multi-hospital perspective, and a large, like at the level of the country as well. So, I'm sorry for what reason. Okay, so I have no disclosure of interest of any of the content of my presentation. And by the end of this presentation, I hope that you are able to identify some key formulary concepts and definitions, just to make sure that we are speaking the same language. And we are also, I hope that by the end of the presentation, you are able to describe the basic infrastructure, workflow, and potential role of the pharmacy and therapeutic committees in overseeing the process of handling and evaluating the drugs in the formulary, and discuss factors related to decision-making process and what are the essential evaluation requirements for successful formulary management. And probably we'll spend most of the time on that perspective, but then during the presentation. So what is a formulary management? The Academy of Managed Care Pharmacy aims for a patient-centered approach in our thought process when we are looking at formulary management, aiming to provide a cost-effective medication therapy, which definitely will lead to achieving target therapeutic outcomes, and keeping in mind that we have to always optimize utilizations of healthcare resources and maintain the access of medications to patients, which definitely would lead to improving the quality of life of those patients. So the center of our focus should always be the patients, and maintaining the supply chain to those patients with having the formulary system. So what is a formulary? A formulary is usually described by the American Society of Healthcare Pharmacists as a continuously updated list of medications and related information. So it's medications and related information pertaining to the diagnosis or treatment of various diseases within an organization or a healthcare system. So it's not just a list. So it's a list and essential information or related information, which include policies, procedures, and your decisions that are integrated in your meetings should also be there within that formulary system. So what is the formulary system? So it's the ongoing process, and it's very important to mention the point of ongoing because it's actually a very dynamic process that changes from a day to day to design policies and procedures on the optimum selection and utilizations of cost-effective medications for certain population. So in the word ongoing process is mainly going with updates in literature and the availability of the medications and the market and shortage and so many of the dynamics of procurement and the availability of drugs and launching of new drugs in the market. And it's been classified to open or closed, and those open formularies are those types of formularies which allow for procurement of non-formulary medications in addition to the formulary medications. And the closed system, those are kind of very limited formularies which they have very specific criteria, or I would say exceptions, to be able to procure medications out of the formulary. Regardless of the name, open or closed, each organization should be able to have a criteria for procurement of medications, the ones that are in the formulary, and there is a criteria for procurement other specific medication to design to specific patient needs. So what is a pharmacy and therapeutic committee? It's an evaluative and educational and advisory committee, works in the capacity to all medical staff within the organization and work as an administrative body in all the aspects involving the medication, starting from evaluation, procurement, storage, utilization, administration, all the steps involved in the medications throughout the institutions. And that's why it's very important to know that there are many subcommittees that can also serve as advisory body to the PNT. And by the way, the name Pharmacy and Therapeutic Committee has been adopted from the US literatures. And sometimes there are like misconception about a big pharmacy. I mean, like some would assume that it's mainly driven by pharmacists, and the name has been changed in some organization to be Drug and Therapeutic Committee, just to make sure that everyone in the organization is on board with the process. And it's been labeled with the same name as Pharmacy and Therapeutic Committee in many international accreditation as well, such as the Joint Commission International, JCI. And there are so many local accreditation that have like specific chapters on medication management and the role of the Pharmacy and Therapeutic Committee. That's apart from the defined role that we know from the ASHP. Most of the standards in these accreditation body are focused on roles and responsibilities of the PNT, which coincides with the ASHP statements. So who are the members? Who sits in your corporate PNT or Pharmacy and Therapeutic Committee if it's just a single hospital? So mainly you would like to have everyone who deals with medications in your hospital. So of course you will have the pharmacists who are going to be your leading and the stakeholders of the committee, but definitely you would have the physician, nurses, pharmacoeconomic specialists, medication safety experts. You need to have members from the Department of Procurement and Supply, Finance, Drug information pharmacists, informatic technologists, you need to have people from quality assurance. And there has been an increased awareness now about having a patient representative and patient advocate to be as members of the pharmacy and therapeutic committee. So you can see this is like going to be a diverse committee which has members from different specialties, aiming to look at the process of medications from all the various aspects. And you can add as many members. The participations of physician to pharmacists maybe would be in a bit of a higher ratio compared to other members in your committee. And there would always be a chance if you invite an ad hoc members of specific specialty. If you have, like, for example, specialty drugs to be discussed, then probably would like to invite the expert on that field during the discussion, for example. So it's kind of a dynamic process where you are able also to have like some of the ad hoc member as needed to make a sound decision. Okay, and P&T in multi-site hospital setting, in general, you would need to have a coordinator. And if it's like several hospitals, you probably would need to have like a coordinator in different institution. And there's always should be someone who is looking at all the issues in one region and report to the pool if you're working in a multidisciplinary collaborative approach. And that's what we have found to be very successful model, in fact, in case of multi-hospital setting, because we were able to unify like our drug formulary requests and evaluation. So we were able to avoid, like duplication of work and kind of have the same standards upon the evaluations of the drug for formulary addition. You would also like to keep track of the attendance, meeting minutes, because there are so many items that get discussed at the P&T, and there are sometimes we're not able to make a decision at one point. So you need to keep track of pending items and make sure you track timelines for making these decisions. And once you have, like the committee has made some decisions, there is a very important part which comes to the implementations of these formulary decisions within your organization and within your electronic healthcare system. And then we'll talk a little bit more about safety and pharmacovigilance. You always should have in your formulary a mechanism for appeal. So if, for example, there has been a decision made for rejection of one drug into the formulary addition, then there should be like a channel for the physician to appeal for that. And you should have a very clear criteria on that appeal, when and how, and the mechanism of that process. Something that is very important to keep in mind as a conflict of interest, like the Institute of Medicine and the American College of Clinical Pharmacists, they have very clear statement, and as well as the ASHP, they have very clear statements on the association between pharmacists and industry and the relationship, and how this process should be very clear regarding confidentiality and conflict of interest. So members of the P&T are expected to disclose their status of conflict of interest on a regular basis. And in many occasions, it's on regular meetings, like in every meeting. And those members who have any potential conflict of interest can either be excluded from the meeting discussion or from voting if they were participating in the voting during that meeting. So it depends on how the extent of this conflict of interest is there. But there should be a mechanism where this has been identified and addressed within the P&T. What are the roles of the P&T in a broad context is that perhaps setting up policies and procedures related to medications evaluation, addition, and use within the organization. There is always a process that should be there to assess all the requests for addition of a drug into the formulary, in additions of procurements of drugs which are not listed in your formulary to meet specific patient needs and demands. You always have to evaluate the off-label use of medications in your formulary and see if that's coincides with the evidence or not, and see how that might have a cost impact on your formulary. You also need to continue to standardize your drug policies and guidelines and CPOEs ordering, so you make sure that you minimize the possibilities of errors and make sure you have an efficient formulary system. There are always lists that comes for therapeutic interchanges or alternative. That list also have to be approved by the P&T. In also the capacity of the P&T, they should be also analyzing a pattern of the drug use through the drug utilization review, which is happening on a regular basis. That should be also give insights on the pattern of practice within the organization, and if there's any deviations from the policies or the guidelines set up by the P&T. Also, the P&T looks at adverse drug reactions and medication safety report and take necessary action within the institution and out of the institution by reporting to other local regulatory and international bodies. Prepare contingency plan to handle drug shortage, and that's very challenging for every institution now, how to handle drug shortage and how to set up, like alternatives and recommendations for that. Disseminating information is also one of the most important tasks for the P&T, and make sure to provide optimum educations on the process of drug use, because if all these policies and procedures and work has been done, it's not been disseminated to the end users, it's not handy, it's not applicable to them, then probably that's going to stay on paper. It's not going to be into practice. And there's also a requirement by most of the regulatory bodies, as well as the ASHP standards, to do like an annual formulary review. And I'll be talking a little bit more about this as we go on during the presentation. So if you think of the workflow of the P&T, you can think about, like the process of an evidence-based, or how you are, like acquiring information. So it goes with assessing the problems, then start with evaluating, like the drugs that you have or the policies that you plan to approve. And then somehow this evaluation has to be standardized, to be systematic, to be evidence-based. And then you then go through a process where you have a panelist of experts, of pharmacists, physicians, and other healthcare professionals discussing that evidence and putting it in the context of patient care. And then there is a decision that has to come up out of that. And that decision it can be changed over time. I mean, it can be something today, and then we can change it in the upcoming few years in light of new evidence or new safety data. And then whatever decision is going to be made, there is going to be an action plan. And this action plan should go into implementation in your institution through electronic healthcare records, through clinical decision support system, whatever electronic system that or even non-electronic system supporting your organization, but somehow the plan should be disseminated. And then you probably need to assess the adherence to your plans and to your policies, and to look at your process of procurement of medication and all these logistics that are following approval of the drug for formulary additions. So that's the part I'm going to spend most of the time talking about. It is evaluations of the requests. And that can apply as well for policies and new drugs for formulary addition. But for new drugs mainly, you need to look at the request and kind of, say, okay, what is the status and the quality of the review at your institution? You need to make sure that you have a standardized process, evidence-based for review of formulary drugs for formulary addition. And once you receive a request, usually there's a screening process that happens through the coordinator of the P&T, who looks at, like, okay, what was the previous, history of this drug into our institution? Did we have previous requests? Did we have previous evaluation for that request? Was it approved? Was it rejected? What were the issues, with these drugs? Because oftentimes we actually receive like duplicate or triplet requests from time to time. And from different, especially if you're working on a multi-site hospitals. So there might be like an application from one hospital over the other one at one point of time. And then you need to probably go back and look into your log of non-formulary requests and see if you have any experience with efficacy or safety of that drug in your institution. Sometimes looking at the log of the non-formulary request shows that you only had it for 1 or 2 patients, and for one reason or another, they did not complete therapy, and you probably want to know why that happened. Or you have it for like 100 patients, and it's like the standard of care now. So this is probably alarming for you, that you should probably give a potential attention to this drug, because you probably want to evaluate this for potential formulary addition. And then you probably look into, is there any undue influence affecting your decision-making or bias? So when you look at the request, you should probably have also a section in the request asking the requester to provide or to give a disclosure of any conflict of interest if he or she has in the request. And we prefer, like departmental requests, so not just only a single request from a single physician. And do you have in your institution like a subcommittee or specialists who will be doing the review? In most of the cases, clinical pharmacists are doing the evaluation, and that has to be discussed in a subcommittee that usually reports to the P&T body for final decisions. And then when you start to do the evaluation process, you have to think, okay, which specialty, would benefit from this drug? So sometimes the drug is requested from endocrine, but that internal medicine specialists, they are also prescribing that medication. So probably when you want to have this drug into the formulary, you probably need to consider all these things, because you need to consider if you need to do some specific restriction, and that could be for certain prescribers, specific indications or population. And then are you going to be able to integrate everything within your electronic healthcare system and clinical decision support to optimize the use of this drug, and how are you going to do it, and how you're going to implement your decision within the system? So it's very important because, as you can see, there are so many things to be done for the P&T. So from a coordinator perspective, I would say it's very important to set up priorities because we receive like a log of requests, and then we have to categorize these medications. So we kind of developed in our institutions a tool, and then we published that, and I'm citing it in here with a group of our colleagues and coordinators from different regions, led by Dr. Layla. So that was kind of a tool that we designed in our institution to help us to screen new formulary requests. So drugs which receive like a high score, more than 70%, we would give it like expedited review, and drugs which are could be simply rejected, the drugs that would have like very low score, and we should have reason for that. And then there are some category of drugs which kind of have an intermediate score, like 30 to 40%. Those drugs will probably do an evaluation for them, but on a routine basis, there is no need to rush for their evaluations. So that kind of things are important to help to improve the workflow and prioritize requests, especially if you have like new drugs, like in case of COVID, like new infectious disease medications and stuff like this, and or drug life-saving drugs, for example. So that's kind of things that probably you would like to prioritize in your evaluation to make sure that your work is efficient within the P&T. So when we talk about the evaluation and decision-making process, there are like three broad, keywords that we all as a pharmacist, when we think about formulary, have to keep in our mind is efficacy, safety, and cost. And in a broad context, I would say it's not just efficacy, it's mostly effectiveness. And when we talk about cost, we're not really talking about a direct cost of the medications, because we need to think about all hidden and indirect costs associated with the use of the medications within the formulary. So a formal pharmacoeconomic evaluation is really needed for an optimal formulary management. And when we talk about safety, it's not just having safe drugs into the formulary. How are you going to handle these drugs? How are you going to monitor them? So we're really talking in a broad context of pharmacovigilance, where you are able to identify some signals as well of adverse drug events, handle this safety issues within your institution, and make sure that you are reporting to regulatory bodies, local and as well as international. So when we talk about effectiveness, the quality of evidence. So when we want to have a drug into our formulary, we need to be broad. We need to be very vigilant about, like what to look at in the evaluations. We really would like to look at high quality. We need to keep in our mind the uncertainty of evidence, especially when we are dealing with some of the medications, like oncology medications. Probably the perspective should be a little bit different than when you're comparing other drugs, and Dr. Mansour will give insights about this. So in general, we are looking at comparative effectiveness research, and we're mainly interested for drugs against active comparisons. You probably don't want to see a lot of discussions in your committees about drugs against placebo studies, because probably it would work. And you also need to look at the burden of the disease within your setting within your country, within your institution, within your load of patients. How many patients do you have of this disease within your organization? So is it like high or low? And what are the clinical outcomes that were addressed at the studies? Are these clinical outcomes that worse for me to pay this extra money and have this drug into my formulary? Or these are like surrogate outcomes that perhaps we're not really sure if it will translate to better quality of life or a better outcomes to patients. And when you look at the population included in the studies, you need to really think about how can you generalize all these data into the broad context of your population in your institution or your setting. And you keep in mind that there are some studies that are conducted in certain settings where there might be some genetic variations from different populations. So that's all things should be considered if your populations are different than the studied population in the studies. And then what is the place of the drug that you're evaluating and in guidelines? I mean, like, is the first line, second line, or is it like a refractory agent that we only need to use for very resistant cases, for example? So you probably need to categorize this when you are doing the evaluation. And if there's any potential for the misuse of the drug, you probably want to be aware of this from the beginning. So you put a strategy for handling this. And one of the most effective strategies that we've been doing in our institution and when I worked at King Abdulaziz Medical City, and it's been widely reported as well in literature to be one of the most efficient process during the evaluation, is doing a class review. And I would just share with you here the study that looked at reviewing about 17 class review in 1 year, resulted in about 5 new therapeutic interchange and met the institutional demands of routine formulary review, and led to about 15 deletions, and provided cost-effective opportunities. Of course, whenever you review your formulary, you discover you have generics, you have alternative. So class review is a very efficient way whenever you have a new drug to evaluate into your formulary. You need to consider, okay, so what are the other agents that we have in our formulary that are used for the treatment of this condition? Do we need all of those? Maybe you probably want to change one of those or remove one of those, or have some restrictions or even delete completely. So it enhances your efficiency of work and gives you opportunity to closely work on your annual review of the formulary to meet the accreditation requirement by most of the local and international bodies, which requires you to evaluate your formulary on regular basis, annual, I would say. So also restrictions, this is something important that has been looked at. So probably would restrict medications for various reasons. And that's kind of restricting the access of prescribing of the medication to certain specialty of physician or certain indications within the organization, or certain age group or place in therapy, like as I mentioned earlier, first, second, third line, depending on the guidelines. And the institutional guideline as well, because there are always broad guidelines, and there are also the institutional guidelines that you design within your institution. So a drug may be listed in the general guidelines as A, B, or C, or D, but in your institution, drug A, you don't want it to be number 1, and you want it to be number 3 or 4 because of the cost, for example. So that's something that you also have to keep in your mind. So the aim of the restriction mainly is to promote safety and to control the cost of expensive medications, and sometimes also it's very important to make sure that essential safety monitoring parameters are done by the expert in the field for this particular drug. Like, for example, all oncology medications are restricted. So systemic review for the impact of restriction has been conducted in one of the studies, and they were trying to look at 2 perspectives. If you can see at the x-axis at the patient outcomes and payer outcomes, and they have looked into various about 37 hospital or something that did like a review, and they saw the impact of this. And in terms of patient outcome, you would see in the blue represents the negative outcomes. You would see it's a little bit high on the patient outcomes, but when you look at the payer outcome, you would see like a lot of positive, significant, or positive, non-significant presented as red or orange. So that's kind of a trade-off that you need to be, I just wanted to bring this to your attention. So there's always a trade-off with a restriction and patient outcomes from a payer perspective and a patient perspective. So it's this balance is very important, that we really want to be rational and optimize resources, but at the same time, we want to make sure that we provide medications for those who need them and not to overdo that. Pharmacovigilance, it's very important when you look at the drug for formulary that you probably want to assess short and long-term safety data. Sometimes you want to defer having a drug into the formulary because we don't have, like enough safety data at one point. And then you need to look at what are the adverse events, frequency, severity, how are you going to handle that? If there is any specific publications on other safety signals, specifically, we encounter this a lot with new medications, newly approved, where we have limited information about safety. And what's very important as well, how does this compare to other agents or to other formulary agents that you have? It's also very important to keep in mind if there are any complexity in the administration or preparation or handling or storage of the drug that may even impact on the safety of the use of these medications. We also need to make sure that we're aware of specific monitoring or precautions before, during, or after. So that should be something that we should have on the table as we are discussing as well the drug. And if we have, of course, there's a role for medication safety in looking into and informatic technology to look into, okay, do we have like a lookalike or sound alike? How are we going to handle this in our, electronic healthcare system? And then what are the potentials for drug-drug interactions? Do we need to put some warnings, some cautions for the prescribers? And of course, there's a special attention for teratogenic drug and hazardous medications handling in your institution that you should follow according to the standard. And the pharmacoeconomic evaluation, as I mentioned earlier, is not just a direct cost. You probably want to look at comparative cost and think about if there are other generics available either for this drug or for other formulary drugs that meets the same indications. You probably also want to see, the indirect cost of monitoring or clinic visits or follow-up in case you have a side effects for one of the drugs and you need to treat that. So how are you going to handle that? You factor this in your cost. And you should also handle this also of cost of administration of the drug. Some drugs, for example, require IV administration. So it requires hospital admission. Is it going to be like 1 day admission, 2 days admission? So lengths of stay also have to be factored. And then also you have to consider cost of switch. Do you have one agent? Are you going to completely switch your patient to the new drug that you're going to have, or this is going to be like an add-on or what? So you have to have, a criteria, because some of the drug, when you're switching patient from one to the other, even within the same class, you probably need to do some monitoring, or even if it's not from the same class, you need to monitor for efficacy of the drug. So that's an additional cost you have to consider if you're doing like a switch from one to the other. Medical cost offsets that you are going to be able to do if you probably prevented an instance of a myocardial infarction, for example, or hospitalization due to heart failure. So these are things that you probably need to factor in your equation when you're looking at cost. So yeah, it's okay to pay this extra money, given that we're going to get this extra benefits of reduced hospital admission, for example. So looking at clinical and health outcomes and factors, and that takes you to calculate the ICER and all these things that in your calculations. And probably as well, you need to consider all the aspects when you look at the patients in terms of quality of life, if cost of transport and lower productivity due to loss of work days because patients are probably are not doing well. So all these things has to be somehow factored in the pharmacoeconomic evaluation. And so this is kind of from two perspectives, institution and patient, and definitely at large, it will serve the big community and society. Unfortunately, it's always very challenging to conduct all these pharmacoeconomic evaluation at various settings, because sometimes we lack important information in certain settings and certain countries about prevalences of diseases, about patterns of prescribing. So sometimes translating like an evidence from an existing literature, from a Western, from a US or European data to local data, sometimes we face a lot of challenges with this transfer. And there was like a very nice paper that was published in one of the Saudi journals by Dr. Al-Aqil, and he was just discussing, like this issue about transferring cost effectiveness data in a broad context. Like he was giving some outlines on this and addressing how, like you should be able to do this transferability, looking at the qualities and the ICERs and various healthcare setting. I'm just keeping it for your reference. It's a very, very nice paper. Since there are some other considerations as well that we also need to keep in mind when we are evaluating drugs. What is the life cycle and the management or patency of the drug? So we always know that we have the drugs being approved, and then there is like a patency period, and then we're going to have generics. So when the generic is going to come up, I mean, if sometimes we receive requests for drugs that is going to be generics in a couple of a year or so. So do we need to get it now, or we just wait for the generic or something like this, depending on the need, depending on the context you are in. We also receive a lot of requests for fixed dose combinations and new formulas, and that has to be thoroughly evaluated because eventually you probably would need to keep the individual drugs, and you're probably going to flood your formulary, and you need to see the value of having these fixed dose combinations, especially with titration of doses. And there's always should be a room to think of, substitutions to new biosimilars available, and that's for biological agents and generics for chemical agents. Pharmacological data as well, and pharmacogenetic data is also very important to be considered if you're having specific drugs that require any specific genetic testing. And in the process of making decisions, there are always cognitive bias that you have to consider. There are like almost about 20 types of cognitive bias that you have to be aware of if you work in P&T committees. And I would really like to go into one that is very commonly being seen, is the expert halo effect, which is actually an unintentional effect that is introduced when you have an expert in the field joining your committee. Because this person is an expert in the field, so there might be some potential influence for this member to other members of the P&T in terms of decision making. So probably you would really like to eliminate that sort of bias among your committee members due to the expert halo effect. And probably you can do this by several strategies been reported in literatures. Is that probably you need to work on having like anonymous voting. It also helps you to avoid any kind of peer pressure. Objective assessment with having an evidence-based drug evaluation, training and educations for your committee members. You need to make sure that those members are expert in, like evidence-based and in interpretation of literature, epidemiology, and they are able to interpret carefully and appraise evidence and make sound decisions. And you also need to have a dedicated time for everyone to, like share their points of view and make a very fair discussion and maintain confidentiality within your committee. What are some other challenges for the P&T? Sometimes the data that we have from cost effectiveness research in clinical trials may not be providing sufficient information for some of the complex formulary decisions. We sometimes face, I would say, difficulty to accept the decision by the physicians or even pharmacists of the P&T. So somehow you need to, as I mentioned earlier, to have mechanism like for appeal in your institution. You also need to think about different populations or clinical services who may need, you need to work for them because you need to meet some gaps in your formulary to provide secure medications for them. And in some of the situation, you may feel, like you lose your autonomy because sometimes, like the discussion goes in one direction and then finally the decision comes at, like at something that's totally different than how the discussion was. So sometimes one feels a little bit, a lot of the autonomy, but at the end of the day, it's a committee decision. And of course, meeting timelines is very important to make efficient supply of medications. So towards a value-based formulary, there are some things that need to be really weighed and balanced. Prioritization, weighing evidence, using patient data, individual patient data. You need to have expertise in drug review, weighing risk and benefits, continuously review medications, monitor them, reduce bias in your decision making, have experiences in the field, and maintain educations within your committee members. And those all would probably lead, if you, as much as you work on all these things within your organization, you probably would have an optimum and rationalized use, and you probably will be able to have a value-based formulary and a cost-effective one. So in summary, P&T should set up the standards, policies, and procedures for formulary management. And the process is not really that simple. It's complex. And as you can see, there are like multi-dimensional, multi-layer, requires a lot of collaboration between various healthcare professionals, and pharmacists play, like, I would say, the backbone of the P&T members and coordination of that work for optimum patient care. And we need to be very aware of different bias and cognitive bias that happens in the P&T. So we're trying to understand the decision-making process and try to address all these aspects in the formulary. Thank you for your attention.
Thank you, Dr. Shireen, for such a wonderful presentation. I would like to ask Dr. Mansoor Ahmad Khan to please go ahead and share his screen and share his experience with us regarding P&T. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks all the participants. Thanks, Dr. Shireen, for joining us very early in the morning, and very insightful thoughts. And we worked together 15 years in the same institution, and I was really enjoying your presentation. Thanks all the participants. Thanks Giving Back to Pharmacy in Pakistan for organizing the crucial workshop, Pharmacy and Therapy Committee. I think we have a cushion of time. So after this presentation, we will have 4 panelists, 10 minutes each, and then we can conclude and summarize in another 10 minutes. So we have a cushion of time, inshallah. So I think what Dr. Shireen has mentioned, Dr. Shireen and I, we have been working in the same institution for about 15 years. And in the last 10 years, or 10 or 11 years, I had been responsible mainly for oncology formulary management. And Dr. Shireen has been responsible for non-oncology formulary management. We are a corporate institution. We have the hospital under the umbrella of the Ministry of National Health Affairs. We have hospitals in Jeddah, Dammam, Riyadh, Al-Hassa, Medina. So we are working in a corporate organization. So in this presentation, what I will try to discuss today is the examples from the oncology formulary management. Okay, I don't have any disclosure related to the contents of my presentation to disclose, and these are my objectives. I think Dr. Shireen has covered everything, but I need to, I thought of providing the examples from the oncology formulary management, and the same thing can be replicated in non-oncology areas, such as nephrology, cardiology, infectious diseases, etc. And we'll try to elaborate the role of the pharmacist, P&T committee, and the formulary management with examples, because the experience that I'm going to share with you is executed by myself and my colleagues in oncology and Ministry of National Health Affairs under the umbrella of the Pharmacy and Therapy Committee. As we know, the vision and mission of the Giving Back to Pharmacy in Pakistan is to empower pharmacists for better healthcare. And for that, we have this organization, Giving Back to Pharmacy in Pakistan, which is an organization of volunteer pharmacists from around the world, aiming to define the pharmacy profession in Pakistan by sharing best practices and engaging relevant stakeholders. It's really great idea, and I feel honored to be the founding member of this organization. And I believe efficient engagement of the pharmacists in Pharmacy and Therapy Committee and formulary management in countries, developing countries like Pakistan and other neighboring countries like developing countries, is perfectly in line with the vision and mission of Giving Back to Pharmacy in Pakistan. And that will provide the leverage to pharmacy profession, to pharmacists to advance their pharmacy practices. And yesterday we had the keynote speaker, Dr. Faisal Sultan. He's the personal assistant to Prime Minister of Pakistan and National Health Services. And he has promised with us and gave his assurances that if we would like to, because Shaukat Khanum Cancer Hospital was admiring and appreciating the model of the Shaukat Khanum Cancer Hospital. So we asked him, can we replicate the same in other private and public sector in Pakistan? And we have great leadership in Shaukat Khanum Cancer Hospital. Dr. Faisal Sultan himself was the CEO. Dr. Muhammad Tahir Aziz, he's my mentor, he's my teacher, he's my friend, and I learned a lot from him. He's the chief operating officer in one of the branches of the Shaukat Khanum Cancer Hospital, and he's with us today. So I think we can replicate the same model of Shaukat Khanum Cancer Hospital in the rest of the hospitals in Pakistan, whether in government sector or in private sector. And we have some people from outside of Pakistan as well. So the same thing can be replicated in other countries as well. So these are some of the outlines where I would like to share with you the role of the pharmacist in Pharmacy and Therapeutic Committee and Formulary Management. I think Dr. Shireen has already discussed in details. We hold this responsibility of clinical evaluation and pharmacoeconomic evaluation of the drugs for addition to the formulary. It's done by mainly clinical pharmacists. And for that, we need to really train our pharmacists to the level that they can evaluate this medication and have the pharmacoeconomic evaluation of this drug. Because as I was discussing yesterday, this morning, that for example, in the field of oncology, hematology, which is one of the fastest and largest growing discipline in terms of drug development activity. So FDA has approved 105 drugs in last year in the field of oncology and hematology. That's really huge number of approvals if we compare it with 2013-14, where we used to see only 15 to 20 drugs. So we have to come up with clinically meaningful outcomes. We have to come up, scrutinize and prioritize the drugs, as Dr. Shih was talking about. And the role of the clinical pharmacist is also there for the development of clinical practice guidelines and drug use policies. And in our hospital, the clinical pharmacists are catalysts. Actually, they are the ones who actually initiate the development of most of the clinical practice guidelines and drug use policies, which come under the umbrella of the Pharmacy and Therapeutic Committee. We do lots of medication use evaluation and also clinical research under the umbrella of the Pharmacy and Therapeutic Committee, and I'll share with you a couple of them. The class review of the oncology drugs is pretty important. Dr. Shireen talked about it. So when you have like one drug that physician would like to add it to the formulary, and if there are other drugs in the formulary, or there are other drugs which can potentially be approved or reviewed, then what we do, we just bring them to the table for the discussion, and that's really has a positive impact on the pharma industry as well. So there is a sort of competition, and we are able to get best out of the best in terms of negotiating the best prices for our institution and for our country. We do periodic oncology formulary review in our corporate organization with an intention to find out the best cost-effective alternatives. And one of the things that we always initiate, and actually it's initiated always by the pharmacist, our clinical pharmacist in the Pharmacy and Therapeutic Committee, is the integration of the biosimilars and good quality generics into the formulary. And reporting and monitoring of the ADR and pharmacovigilance, Dr. Shireen talked about it, this also comes under the umbrella of the Pharmacy and Therapeutic Committee. Now let's share with you some of the examples of the MUEs and clinical research that we have actually done. So the first MUE that I would like to share with you, or the first study that I would like to share with you, is the medication use evaluation of recombinant human factor 7 for hemophilia A with inhibitors. So we found out from 1995 up until 2015, one of the most expensive drugs on the budget of the Ministry of National Health Affairs was factor 7. And it was costing us about 35 to 40 million reals per year. So we had a resident, so we assigned this project to her to do this medication use evaluation to find out where is the use, what is the most common indication. And we found out actually there are 3 patients, hemophilia A, with inhibitors, and they are the ones who are costing us 95% of the expenditures of the factor 7. And not only this, we also found out that these patients are getting admitted to the hospital around 24 times per year for the management of the bleeding episode. So despite the fact they are receiving prophylaxis to prevent the bleeding episode in hemophilia A with inhibitors, we have to use the bypassing factors. It was not protective. The patients were still coming to the hospital, and each admission for the bleeding episode management is costing us about $250,000 to $500,000 reals. So that's another hidden cost associated with the factor 7 use. So then, as a PNT member, as a clinical pharmacist, we try to look for the alternatives which are cost effective. That means more effective and costing us less. So we came up with FIBA as one of the bypassing agents. And in the literature, we found that around the number of the admissions for the bleeding episode is about 7 or 8 per year. So we switched from factor 7 to FIBA as a prophylaxis that resulted in direct cost saving of about 15 to 20 million. Not only this, we reduced the number of admissions from 24 to somewhere 0 to 1. That was significant, impact on the overall quality of life of patients, as well as on the saving the resources of our hospital. But the patient still had to come to the hospital 3 times per week. That means 52 times 3 is 166 times. 156 times they have to come to the hospital to take 1 to 2 hour infusion of FIBA. Then we try to look for the alternatives of the FIBA as a bypassing agent to be used as prophylaxis for these kind of patients. And we came up with emicizumab as one of the cost-effective alternative, which is monoclonal antibody. A patient can self-administer. It's subcutaneous. It can be used once weekly, once every 2 weeks, once every 4 weeks. And it's costing 1 million real per patient per year, cheaper than the FIBA. So that's the benefit of doing the MUEs, and that's the benefit of doing the class reviews, therapeutic class reviews. You bring the industry to the table for the negotiation, and you can best of the best. And we recommended addition of emicizumab to Ministry of National Guard Health Affairs based on our MUE findings. And now, in last year, we did not see any patient getting admitted for the management of the bleeding episode since we started patient on emicizumab. And no patient is coming to the hospital for the administration of the emicizumab as it's self-injected subcutaneously. We published this paper in one of the American journal last year, and that is resulting in significant improvement in clinical outcomes. Another study that I would like to share with you, we recommended to use respiratory case 6 milligram fixed dose strategy in our hospital. It was recommended by actually myself and my team from the clinical pharmacy. And, as in comparison to the FDA recommended dose, which is 0.2 milligram per kg once daily for 5 to 7 days, is costing us much more. And not only this, sometimes we don't have enough amount of respiratory case, not only in Pakistan, even sometimes in Saudi Arabia, we do not have enough respiratory case. So we try to go back and look at our practice, and we found out that 6 milligram fixed dose strategy is as effective as multiple day dosing. And we published this paper a couple of years ago in the American Journal of Hematology and Oncology Pharmacy. And then the PNT committee has recommended the guideline and has recommended 6 milligram fixed dose strategy. Another study that I would like to share with you, which we did with an intention to reduce the cost, and actually with not only cost, but also the clinical outcomes as well. So, the chronic myeloid leukemia is a chronic condition where the patient has to be on some kind of TKI therapy. Of course, the outcomes have been improved after the revolutionary approval of the imatinib, followed by dasatinib and nilotinib, and bosutinib. But these patients have to be on some kind of therapy throughout their life. And the international guideline does not provide clear recommendation when they can stop it. So what they recommend is to continue lifelong. But we saw a couple of studies a couple of years ago, 3-4 years ago, that the patient can actually go off therapy if they have deep molecular response, which the BCR-ABL copies undetectable over 2 years, and then they can go off therapy. And on 30 to 40% of those patients, they actually don't require therapy after that. And most of the patients, those who molecularly relapse, they can respond back to the same therapy. And most of the patients, those who relapse molecularly, they actually relapse within 6 months. And you can see this was one of our resident project, PGY2 Oncology resident project, and I was supervising this project. So you can see the primary outcome, which is the TFR treatment-free remission within the 6 months, was 90%, 92%. And then at 1 year follow-up, the 17% patient did not complete the follow-up, but almost the same number is in TFR at the completion of 1 year. So this study had resulted in cost saving of 5.8, nearly 6 million reals, using the Saudi FDA listed prices for imatinib, dasatinib, and nilotinib. Not only this, we can, there is a hope that we can offer treatment-free remission to our patients. So in countries like Pakistan, the patients are either paying out of their pocket, or the government has to pay for some government employees, but other patients, they have to pay out of their pocket. And in Shaukat Khanum Cancer Hospital, it's a trust organization. And we definitely need to work out these kind of strategies to offer treatment-free remission to our patients. And not only this, so it's not only the financial toxicity, it's also the physical toxicity and the psychological well-being of the patient. If they can go after, they don't have to take any medication, they're definitely gonna feel very good. And we have applied the TFR strategy in the Pharmacy and Therapeutic Committee as one of the cost-effective strategies. Now, we have some cost-effective alternatives. We recommended botulisumab versus lenalidomide post-transplant multiple myeloma, which resulted in 50% cost saving. We recommended panitumumab versus cetuximab for KRAS wild-type metastatic colorectal cancer patients with significant cost saving. I know in Pakistan, probably, I know Shaukat Khanum, probably they are controlling the Pharmacy and Therapeutic Committee very well, but I'm not sure about the other private sector, the government sector. Pharmacists really need to play an important role here to come up with the cost-effective strategy, because most of the people are paying out of their pocket. We recommended weight-based dosing of nivolumab over fixed dose, which is saving 100,000 reals per patient per year, which is really cost-effective. Then one of the chairmen of the Lymphoma Society in Saudi Arabia wanted to use brentuximab in combination with AVD in advanced classical Hodgkin disease patients for 6 cycles. And based on the Echelon trial, when we reviewed that, the 2 years progression-free survival in classical Hodgkin disease in advanced setting was only 5% better in patients those who received brentuximab in comparison to ABVD. So, well, the ABVD is costing us like 1,000 real per patient for 6 cycles, whereas AVD plus brentuximab is costing us like 250,000 to 500,000. So then we reviewed this, and then we discussed this with not only our hospital, we discussed this with Saudi Oncology Society, we discussed this with Oncology Lymphoma Society chairman, and he is a friend of mine, and he agreed to drop brentuximab from the Saudi Oncology Society, from the Lymphoma Society, not to use brentuximab upfront. So that's what I'm trying to say, like in countries like Pakistan, where the physicians have monopoly, and it's pretty difficult to challenge them, but we have to step up. We have to step up and protect our patients, protect our country, protect our institutions from misadvented use of these kind of medication. So we have to see really the clinically meaningful outcome before using these kind of medication. We recommended, this was actually my recommendation, to use inotuzumab or blinatumomab for relapsed refractory B-cell ALL. It's 2 times more effective, 3 times more cheaper. For blinatumomab, patients have to be admitted, hooked for 28 days in the hospital. Inotuzumab can be given in outpatient on day 1, day 8, and day 15, just as IV, which is more effective. So that's what Dr. Shireen was talking about. So it is much more safer as well. So blina has lots of toxicities. Inotuzumab is much more safer. So all the 3 pillars of the cost effectiveness, inotuzumab was much better than blinatumomab. And I'm sure people are using blinatumomab and inotuzumab both, but I always prefer, and I always educate my team, my medical team, to use inotuzumab over blinatumomab if they have CD22 expression positive. We approved generic imatinib, not the Indian version. I don't recommend Indian version of imatinib. That's really not effective. But good quality generic, FDA approved, the national regulators approved, like EMA approved imatinib is really good. That's saving us like 50% of what we used to spend on Gleevec. We recommended Akynzeo, which is 40% cheaper than the combination of Ganistran and abritinib. And in countries like Pakistan, I presented this slide when Dr. Tahir Aziz invited me for oncology symposium in Pakistan, Shaukat Khanum Cancer Symposium in Pakistan a couple of years ago. I presented this slide there. Pertuzumab is one of the anti-heterogeneous monoclonal antibody which can be used in adjuvant setting as well as metastatic setting as well as in neoadjuvant setting in heterogeneous positive breast cancer. It is justified, its use is justified in neoadjuvant setting as well as in metastatic setting, but it's not having any clinically meaningful outcome when it is used in adjuvant setting, which is after surgery. The primary endpoint was the invasive disease-free survival in patients those who received pertuzumab plus trastuzumab dual combination versus trastuzumab alone. It was only 1% improvement in the invasive disease-free survival, 7.1% versus 8.7%. But that costing a Pakistani, one patient, 5.56 million Pakistani rupees for a very marginal risk reduction. And in Saudi Arabia, it's costing about 450,000 riyals per patient for very marginal benefit. So we recommended not to use pertuzumab in adjuvant setting in our hospital. And also, I did not recommend this in my symposium. This was my suggestion. I did not suggest this to be used in Pakistan in adjuvant setting, but I'm sure in private sector where the patients are paying out of their pocket, some physicians might have been using it. So we're not using this in Saudi Arabia in adjuvant setting, whereas the Saudi Arabia is a very rich country. Integration of the biosimilars and good quality generics into the clinical practice is really great way of saving. And I will skip this. So we had been spending, this is the expenditures of the top 10 expensive drugs in bevacizumab, rituximab, and trastuzumab had been the top 5 most expensive drugs in the budget of the Ministry of National Guard Health Affairs. We published a paper a couple of years ago, last year actually, in one of the American journal. We anticipated that we'll be spending 65 million riyals on these 3 blockbusters. And then we recommended that if we switch them to biosimilar, we'll be saving around 50% of them. And this is the formulary management and P&T recommendation at our corporate organization, and we have achieved 30 to 34 million riyal saving, which is exactly what we have anticipated in our paper. And believe me, this is initiated by our pharmacy team, by our pharmacy team in the Pharmacy and Therapeutic Committee. And this slide, in the same paper that we published, we had shown the switching from Neupogen to biosimilar Zerzio had resulted in 60 million real cost saving, which is corresponding to $16 million in 5.5 years. And this is the implementation of the biosimilars in oncology at National Guard Health Affairs. Believe me, this is the stakeholders for this is, of course, physician and pharmacy, but the initiative has been taken by the pharmacy. Lastly, I'll talk about the class reviews in the management of the oncology formulary. It's really important. Dr. Shireen has talked about it already. Objective of the class review is to have the best out of the best in the class in terms of the cost, efficacy, safety, and the cost. And the therapeutic class review should not be so broad and inconclusive that it becomes meaningless. It should be meaningful, actually. Dr. Shireen talked about this study, which was published, of course, in colleague in P&T journal 8 years ago. And I suggest that after the conclusion of this workshop, we can come up with a paper and publish the same paper in the same journal, P&T, in 2013. And Dr. Shireen and I can work with the other team members. So they basically had come up with the novel approach of the formulary evaluation using class review approach. So this was the Nebraska Medical Center. They evaluated 17 drug classes within the same year, and they came up with 3 formulary additions, 15 deletion, 5 therapeutic interchanges, and drug safety issues were requiring action was 6 drugs. And really, whenever you do the class review, this is my experience. So whenever we do the class review, then the pharma industry come and approach us, and we ask them to contact with our logistics, supply chain, and pharmacoeconomic department for the negotiation. And believe me that we have done many class reviews, but one of the class reviews that I would like to share with you is the CDK4/6 class review. There was very expensive drug. It was costing 25 million riyals per year. And then when we then we started the class review of the whole CDK4/6 class. The cost was reduced from 25 million per year to 6 million riyals because of the competition that we had. Then I would like to share with you briefly the class review of advanced RCC that we have presented. I presented this in Corporate Pharmacy and Therapeutic Committee in October 2020. And this is the NCCN guideline, which categorized the patient critical risk and poor intermediate risk. In favorable risk, the preferred regimens are axitinib, pembrolizumab, pazopanib, and sunitinib. And poor intermediate risk, we have two category 1 recommended treatment options, ipilimumab and nivolumab, and axitinib plus pembrolizumab. We used to have the sunitinib or pazopanib as a standard of care therapy for advanced RCC up until 2018, 2019. But in the era of the immuno-oncology, the nivolumab, ipilimumab, pembro, axitinib, and nivolumab, axitinib is the new standard of care, actually. Now there is another one, cabozantinib, in combination with nivolumab, which was not approved at that point in time for advanced RCC. So that's why I didn't include it. So these were the 3 randomized control trials that we went through, Checkmate 214, which evaluated Nivo-EP combination, and they compared with the previous standard of care, sunitinib. The Javelin Renal 101 trial, they compared avelumab, axitinib in comparison to sunitinib, the previous standard of care. The Keynote 426 compared pembrolizumab, axitinib combination versus the previous standard of care. The primary endpoint was progression-free survival in all these 3 randomized control trials. The avelumab was not approved by Saudi FDA, so we dropped it from the class review later on. This is the progression-free survival for 3 randomized control trial. You can have a look at the Checkmate 214. We had the 4 years data for PFS and overall survival presented by Dr. Albajiz in ESMO last year, and that had shown that the PFS was significantly better with the Nivo-EP combination versus sunitinib 8.3 months, 11 months versus 8.3 months. And in Keynote 426, pembrolizumab axitinib performed really well in comparison to sunitinib 15.4 months versus 11 months. But you have to look at some of the key differences in this clinical trial population as a pharmacist. For example, the PFS in the pembrolizumab axitinib Keynote 426 in the control population is 11 months, whereas it's 11 months in the intervention arm of the Checkmate 214. The main reason is that when I try to find out the reason, there were more favorable risk patients included in Keynote 426 that resulted in enhanced magnitude of the therapeutic efficacy in the Keynote 426. Similarly, in Javelin Renal 101 trial, the PFS was better in the combination versus the sunitinib, and overall survival was also better in the combination versus the sunitinib. We dropped avelumab axitinib combination because it was not approved by Saudi FDA. We looked at, this is how we look at the price comparison. So the median duration of the treatment for Nivo-EP was 8 months, and pembrolizumab and axitinib was 10 months in Keynote 426. The cost of therapy, if you use weight-based dosing, this is our recommendation, it will be 267,000 riyals in our hospital versus 570,000 riyals. So there is a difference of around 300,000 riyals per treatment, per one patient treatment. Another thing is that, you know, there were many pharmacoeconomic evaluation that had shown that Nivo-EP combination was associated with improved cost per responder per treatment, or cost per responder, you know, because they don't, many patients actually went off therapy due to adverse drug event, but they were still in treatment-free responses. So this is the price comparison. So Nivo-EP was 267,000 riyal versus 570,000 for pembrolizumab, and sunitinib is 99,000 and pazopanib 44,000. But pazopanib and sunitinib did not do well in the intermediate poor risk, but they can do well in favorable risk. So that's why we came up with the recommendation that the pazopanib is the more cost-effective in first-line setting in this group, and Nivo-EP is the most cost-effective immunotherapy-based combination therapy in this group. And we are controlling this in terms of clinical practice guideline from the pharmacy and therapeutic committee. So now we can move to the panel discussion at pharmacy and therapeutic committee, and this is going to be interactive, so we can ask each other questions. So the first panelist will be Dr. Zahid Aziz Mul. He's my mentor, he's my teacher, and I have learned everything from him actually. And we'll start with him so he can share his experience at Shaukat Khan Cancer Hospital, followed by other panelists, but it is interactive discussion. Thank you so much. Dr. Zahid Aziz Mul, please.
Well, thank you very much, Mansoor. Thank you all. And I really appreciate on the presentation, a very thorough, fantastic presentation. I mean, you have both done very well. I mean, there are a lot of things on the board. Before starting, I think I would like to, give some, appreciation to the audience, because we are listening to both of you for the last 1.5 hours. So, you can think about the empathy the students or all audience showing towards you. So I really appreciate all audience who are still there for the last 1.5 hours. Coming toward my experience, before going to my experience, I will share a few of the things. After doing all these things, what I believe that PNTC basically is not an administrative body. I believe it is meant to be a little bit more consultative and to provide oversight. And in the main, I think this is the major function of the body. And whenever we are talking about to establish a PNTC within a hospital, so I think this is very easy, we can doable, but in a stepwise manner. And when we talk about, with reference to in Pakistan, so obviously this needs a little bit joint collaboration, obviously, of all stakeholders, mainly the Pharmacy Council, you can say, healthcare commissions, TRAP, all can play their vital role, obviously. And again, once you do and once you move on this, you have to look at the complete gap analysis before going for appropriate and representative action plan. I would like to add one more thing here, because during discussion it came that there are only one hospital in Pakistan, that ASCM. I don't think so. There are a lot of other hospitals are there which are running a very good pharmacy services. I would like to take the name of these hospitals mainly. Aga Khan Hospital, we have a very good pharmacy system. I'm sure they have a good PNTC committee system. We have a Shifa Hospital in Islamabad. And there are other few institutions as well. If I'm not mentioning some of them, maybe I missed, but there are a lot of other ones as well. But in Pakistan, if you have to look at, hardly not a double figure numbers are there, hardly, very few hospitals which have a very good, PNTC or pharmacy, hospital pharmacy services. So as earlier I said that if you have to look at, PNTC perspective, I believe that the most important part of the PNTC is basically the pharmacist itself. Basically, he is the secretary, he is the main driver of that committee. And you have mentioned so many examples here. Dr. Shannon has shared so many examples here. And I have, deduced one of the major results, one of the commonality between both of your presentation, that the knowledge and the competency of the pharmacist is the prime importance. And when I'm saying the knowledge, so the knowledge becomes power only when we put it into use, actually. I always not much impressed with this, because I believe that the knowledge is knowing that, a tomato that is not a fruit, but wisdom is not putting it in a fruit salad, basically. So how a pharmacist is competent and play a role and then drive PNTC. But obviously, whenever we are talking about the pharmacist role, then we have to look at the foundation. Do we have a foundation of the PNTC, good foundation here in Pakistan? So I think it has been discussed many times. So the current situation in Pakistan, if you look at the public hospital, you are very well aware about this. You have some idea of the SAMI public, some of the SAMI private hospital. Like AKU, again, Shifa and ASCM, they have a good PNTC committee meeting. They have good pharmacy services. But still, we have some problem within the public sector. And I'm not discussing in detail, but obviously, developing countries have a very good foundation system. So firstly, I think I would like to emphasize that all stakeholders must think about how a good foundation may be developed. How can we develop within the Pakistan so that we can start a good pharmaceutical and PNTC committee services. Once we've done this, then we have to come into the formulation of the PNTC. I hope everyone have a good idea. How can we formulate the PNTC? And second step is basically the chairperson. How the chairperson who is leading the PNTC, how he is innovative in a sense, how their involvement in that PNTC. So this is very important issue, what I believe, in the performance, in the effectiveness of the Pharmacy and Therapeutic Committee. So if the chairperson is very innovative, he is very involved, then I hope the Pharmacy and Therapeutic will be flourish. And obviously a multidisciplinary approach, you have already, I'm not going in detail. And last point, I would like to emphasize more only the effectiveness, basically. And you have discussed so many points on the effectiveness of PNTC. I agree with this. We must have to think about some of the indicators. You have already discussed few of the indicators. Mansoor, Dr. Sharon has already been discussed. And I totally agree with that. These are highly, excellent indicators. And one can easily adopt this, like rate of medication error, reviews, control of cost, pharmacoeconomic analysis, and obviously, how we are mandating and formally items in the list. All these things have been discussed in detail as well. So once again, I would like to congratulate all of you, giving back to pharmacy in Pakistan's. Credit goes to whole team who has, conduct this an excellent session. So keeping with the time, over to Mansoor. Thank you very much.
Sir, we have a question. In pharmacy in Shaukat Khanum Cancer Hospital and Research Center, how is the structure right now? And how many members from the pharmacy do we have in PNT committee?
So, well, as I earlier said, we have PNTC committee. This is a centralized committee. If you have to look at our structure, so we have a centralized pharmacy and therapeutic committee that's actually covers all hospital of Pakistan. So say example, we have a ASKM Lahore Hospital, we have ASKM Peshawar Hospital, and then we have, KDC, Karachi Diagnostic Center, where we have a very small pharmacies there. And obviously in future, we are opening a new hospital in Karachi, and they have obviously a very good, a very big setup of the pharmacy. So here we have a centralized pharmacy and therapeutic committee meeting. The secretary of the pharmacy is head of the pharmacy department, which is actually, sit in, in the head office pharmacy in Lahore. Their members include obviously all pharmacy head of all campuses. And this is chaired by our chief medical officer. We have all members who have already done this here, list on all, procurement, personnel, QPSD personnel. We have 2 or 3 doctors from IM, 1 doctor from, oncology setup. We have 1 doctor from surgical setup. So we have, almost more than 15 to 16 members of the PNTC committee right now at the moment.
Thank you. Dr. Tahir, just one more question. How many clinical pharmacists sit in this pharmacy and therapeutic committee? I would like to share with you. We have formulated a balanced composition, and that's actually everywhere in the United States as well as with hospitals. So 50% physicians, 50% clinical pharmacists, and we have some ad hoc members. So for example, if there is an infectious disease drug, so we invite infectious disease clinical pharmacists to come and present, the one who has evaluated the drug. So do we have other clinical pharmacists attending the pharmacy and therapeutic committee in Shaukat Khanum? And who is evaluating the drug in Shaukat Khanum? Drug evaluation.
Yeah. Of course, we do have a clinical pharmacist, and these are the member of pharmacy and therapeutic committee. We have, some co-op member as well. So whenever any doctor we would like to call in a case we have a drug which is relevant to infection control, say example, we have antibiotics. If we have a drug, say example of cytotoxin, so obviously we can call, consultant as a guest. So, but what you are saying is a 50-50%, or we don't have a 50-50%, but we have a very good number. If you have to look at the numbers, we have 1 and 2 clinical pharmacists right now at the moment, which are the member of the PNTC committee.
So can we increase this number?
Yes, this will be increased sooner. We have a, actually we are working a little bit more now. It has been discussed a few months back. We are trying to, restructuring a few of the function of the pharmacy, and most probably this will add more pharmacists in the PNTC committee. Yes.
Dr. Sheen, you have any questions from Dr. Tahir?
No, I just noticed a question on the chat about a preference for IT systems that would suggest pharmacy prescription and medication errors. Well, I think this is something that, every institution should look into carefully. There are so many reporting systems that are available in hospitals, and somehow some of the institutions are able to have this integrated with their electronic healthcare records. So I think that there are so many options, so many companies available providing their products, but it has to be carefully assessed to meet the demands of the organization. I don't have like a preference for one because we've used some of them in Saudi Arabia, and I learned that there are some others which are best, like Apex, for example, but I haven't used it myself. But the most important thing is that whatever system you're gonna have for your ADR, try to have like something that could be easily integrated within your electronic healthcare system, because we face the problem sometimes that you have like multiple systems within your organization. So you don't talk to each other, and you're depending on human to get data, you know, like from one to the other. Like if you have a safety alerts documented, and then someone has to physically go and document it in the other system. So that's a kind of a problem, yeah.
You know, Dr. Zahid is PhD in informatics system, and he is the hero of, you can say, South Asia. He invented a system which is sold in United States and Europe.
I'm so sorry. I just that was a question in the chat. I'm not really sure.
It's okay. It's okay. Well, I think Mansoor have a good idea about how much. I mean, we have a very in-house, hospital information system, and this is developed by our own team, MIS, Management Information System Department, and we are working for the last, since 2001. You know, we haven't developed in one day the system. It took at least 15 years to develop a good pharmacy management system. So if we have to talk about pharmacy management system, so you know, all systems are integrated to each other. So suppose if I'm prescribing, someone of the prescriber prescribing from one of the city of Lahore, so I can easily review their notes. I can easily monitor the patient here as well in another city of the Pakistan. So all our hospital information are integrated to each other. All modules are integrated to each other. Keeping in view, we have a good CPOE system. We have a good, e-learning system. And overall, I can say it's a total ERP system now. We can say enterprise resource planning system we do have. Moreover, we have a good clinical decision support system as well. So we know we have some papers we have, published in recent, for the last 3 or 4 years on only how we have developed a good clinical pharmacist manual, where a pharmacist can review, where a pharmacist can do a pharmaceutical care plan, how they are developed. We have a very good alert system. We have a good pop-up system. The system automate, checking the dose, the drug interaction. They have also checked the normal lab system. And they also have a good, check with the reference to allergy, each and everything. So we have so many other functions as well, which are very good developed within our system. So, if I would like to move on the HES, only though I can discuss more than 1 hour on that. We have very good integrated ADR, AD, each and everything. Whatever you ask, I think it has been embedded within our system. So I think, keeping with the time again, we have so many other, my friends are here, Salva and Shwab, and another one, Shamim, was here.
I think we can go to Karachi now, one of the biggest top 2 or top 3 cities in the world. Karachi, Dr. Sayyid Shamim Raza from one of the state-of-the-art hospital, Pakistan University Hospital. Dr. Shamim Raza, please, can you please share your experience, your organization?
First of all, thank you very much, and assalamu alaikum to everyone. So I was just talking and chatting with Zishan that since 3, I actually reinvented myself, because this is my 22nd year in the hospital operations. But Dr. Shireen's presentation is very well, it's very well articulated, and it actually, whatever we are doing right now, it is a good reminder. There are some certain points in our presentation, which I think at times we're just taking as granted, but it has a lot of support as far as the backup literature is concerned. There are certain things which are related to the best practices which we're talking about now. as Tahir just also mentioned about there are variations and there are practice variations. Saudi Arab or even USA, and borrowing the terminologies in the private institutions like, let's say, Aga Khan University Hospital, we were very fortunate because since 1985 this is a private teaching university hospital established on the rules and regulations, or let's say the standards, not rules and regulation, but on the standards of the North American things. So we were very fortunate at that point of time that majority of the hospital leadership actually came from United States. So I can fairly say that since the inception, the Pharmacy and Therapeutics Committee exists in Aga Khan University Hospital since 1987. But it has, since the beginning of the hospital's operations, and now it's a 34-year-old. I can fairly say it is the first ever Pharmacy and Therapeutics Committee established in any private teaching university hospital. And then subsequent to the other institution we just mentioned, Tahir, about the Shaukat Khanam Hospital and Shifa Hospital. But the encouraging thing is that majority of our pharmacists are now somehow or the other working in public and the private hospitals. So those who work with Aga Khan Hospital, let's say in the Shaukat Khanam Hospital, and now moving to the other sites of the hospital, they are trying their level best for establishing their local pharmacy and therapeutics committee, whether it's the public hospitals or the private hospitals. So I disagree with the numbers which my colleague Tahir said about hardly the number could be in the double figures. No, it's not the case. There are, I think, more than dozen hospitals, both public and private, where the pharmacy and therapeutic committee in any form exist. Now it's fully function on the basis and the merits. That is a different thing. But at least the certain steps are taking in order to establish that kind of a thing. So, well, as my colleagues and both Mansoor Sahib, you and the Ms. Shireen touch base about the theoretical perspective or the terminologies related to administrative, educational, and advisory role of the pharmacy and therapeutics committee. So the pharmacy therapeutics committee, as you all are mentioned about, responsible for overseeing an institution or let's say healthcare system like Shaukat Khanam Hospital and Aga Khan Hospital. We have we have a teaching university hospital in Karachi. Then we have a sister organization, same in Aga Khan Hospital, Nairobi, and in Kabul, the FMIC, the French Medical Institute in Kabul. Now we are opening an hospital in Uganda also. So it's sort of a one one AKU concept, but in 4 different regions. So obviously the laws and regulations are different, but the basic theme of the Pharmacy and Therapeutic Committee remains the same, and that is particularly focus on the formularies. So I can just say like this, that the PNTs are responsible for overseeing the institutions and the healthcare system formularies. And the list of these medications approved for prescribing, and the primary task is to develop these formularies based on, like Ms. Shireen said about, the safety, efficacy, and obviously the economics, because the many also balance the goals with consideration of the cost effectiveness. So these are the things. So since the beginning, like as I said, at 1987, the Aga Khan University Hospital Pharmacy and Therapeutics Committee is a very active pharmacy and therapeutic committee. We the it is also a changing, I must say, after getting we are the first hospital in Pakistan who received the Joint Commission International in 2006. And from Monday, the coming Monday, from 20th September till 24th September, we are going for our 6th reaccreditation survey. So, so it's a pioneer in terms of, the Joint Commission. So we've changed our terms of references based on the Joint Commission international standards and the measurable elements. Also, the local laws and regulations set by the Drug Regulatory Authority of Pakistan. We have in our Pharmacy and Therapeutics Committee also have 4 subcommittees. 3 are the permanent subcommittees. The one committee which is looking after the formulary review, so that all the technical papers and requests for addition of the drugs, or let's say the consumption pattern of the drugs, have been taken care by this formulary review committee, and the final decision has to come to the Pharmacy and Therapeutic Committee for addition of the drug or deletion of the drug or addition of the class or a drug use evaluation or a drug use review. That's the one subcommittee of the P&T committee. The second subcommittee of the Pharmacy and Therapeutics Committee of Aga Khan University Hospital is Antibiotic Stewardship Committee. So this committee is entirely looking after the overall usage of the antibiotics, both inpatient and outpatient, and is being chaired by an infectious disease consultant, with the secretary is a clinical pharmacist who is also a board certified infectious disease consultant pharmacist. The third committee basically is our immunization subcommittee. So we looked after the immunizations, the routine immunizations, the government sponsored program of EPI, and that also have the pharmacist and the representative from the nursing and the physician side as well. Fourth committee in this time of the COVID is being formulated. That's called a COVID-19 expert group that actually come up with the policies and procedures related to the drugs, because in the COVID there are a lot of things related to experimental use or emergency use. So it was a responsibility of the Pharmacy and Therapeutic Committee to make sure to come up with certain guidelines in terms of the restriction, in terms of the judicious use of certain experimental drugs into the hospital. So that group is also worked around. Our P&T committee is also emphasized on the educational perspective. So whether it's an education of the nurses, education of the physician, and education of the pharmacist, they actually very much supportive in terms of that concept of the hospital, because it's a teaching university hospital. So right after JCIA, our P&T committee also approved the concept, and the hospital administration also supported that. We are going for ASHP residency program starting in the Aga Khan University Hospital, which is going to be another, another innovation, or it can create an environment where the pharmacists can also boost their capacities in terms of the medication safety and a patient safety advocate. We have a clinical trial unit also, where we are deputed all the pharmacists who are actually trained on the basis of clinical trial or investigational drug use in the hospitals. So whether it's going to be ICH guidelines or IHF recommendations or GCPs, as far as the clinical trial drugs are concerned. So our Pharmacy and Therapeutics Committee somehow or the other looking after the clinical trial drugs used in the hospital as well. So these are the things. We have certain collaboration with the government and some non-government organizations, and as a part of the International Teaching University Hospital, we have a good relationship with certain organizations, like this ISMP and the Johns Hopkins University, because of the dean is from the Johns Hopkins University, and one of the member of the Pharmacy and Therapeutic Committee from Anesthesia Department as a chair of the anesthesia. He just recently came from University, Johns Hopkins Universities. So we have that kind of structure available, where we are just judiciously using that. Yes, We are also facing challenges related to formulary requests, and as the conflict of interest. I don't say it's a conflict of interest, but Pakistan is a big canvas as far as the drug registration is concerned. If we have to review a class review, let's say for example, proton pump inhibitor. So only proton pump inhibitor in Pakistan, more than 150 salts have been, available in the market in a form of generics. So sometime it become a very challenging task when you received a prescription from your gastroenterologist or a general physician of X or Y or Z company. So the Pharmacy and Therapeutics Committee has that kind of a role that to establish some sort of the scoring methodology which Shiri just mentioned about. So last year we developed that kind of checklist also in order to further robust our selection process, and anybody or anyone can come and do the audit. So they didn't find um, any sort of conflict as far as the selection is concerned. I think I'm done with my 10 minutes. If any burning question and anything, I'm open to respond. But thank you very much, and thank you the team of giving back to Pakistan, pharmacy in Pakistan. We always support that cause. Thank you.
Thank you so much, Dr. Shamim. I think it's really nice to speak to you. This is our first ever meeting, and you and I, we probably have the same number of years of experience, 22 years, mashallah, barakallah. And it's good to hear from you. Khan University Hospital is one of the finest state-of-the-art hospitals in Pakistan in the private sector. And you really have a great structure to be into committee. But I just have a couple of questions. So how is the composition of the Pharmacy and Therapeutic Committee? How many pharmacists do we have in the committee at AKU? And who does the drug evaluation?
Yeah, so Mansoor, thank you. We have around 21 members, main Pharmacy and Therapeutics Committee. So in those 21 number, there are, including me, there are 3 more pharmacists. So one is, and 3 are, 2 are the clinical pharmacists who are basically supporting and who are also the member of the formulary subcommittee. And one is the member of antibiotic stewardship committee, and one is the member of immunization committee. So all these 3 members are part and parcel of the subcommittees, and they have a clinical knowledge, and they have some board certification and the certification. So their input is very valuable when it comes to discussions, and in terms of making the drug evaluation monographs as far as the selection of the drugs is concerned. We have a drug and poison information center equipped with some latest software and the licensed software like Micromedics and Iowa Drug Information Systems is concerned for the latest research. And we have a journals like the formulary is coming every month online, and a subscription of various peer-reviewed journals. So so that's the membership of the PNT committee, including all the services related to anesthesia, pediatrics, general surgery, internal medicine, infectious diseases, quality controls, nursing services, from supplies and purchase department. We have a representative. We don't yet have the representative from the finance, but that could be coming days. This could be one. They could be one of the co-opted member.
So the thing is that, the reason I'm asking this question, so sometimes we have, for example, specialty reviews, like, for example, there's an oncology drug. So my question is, who evaluates the oncology drug and who presents it? So ideally, it should be one of the oncology, hematology, clinical pharmacists, not the regular pharmacist, the regular, internal medicine pharmacist. And the other thing that I was going to ask you, you mentioned it already, finance. I can suggest instead of finance, what we have in our formulary in the United States is the pharmacoeconomic specialist. So can we have the pharmacoeconomic model in AKU? Can we establish it? Can we have the members who can do the pharmacoeconomic evaluation, the true pharmacoeconomic evaluation, not just the cost comparison, can we include them, and can we increase the number of pharmacists equivalent to physicians to balance the proportion between the physician and pharmacist?
Yeah, but Mansoor, as I mentioned, the hospital is investing on the capacity building of the pharmacists. As you just mentioned about, I know that oncology is very near to you, based on your experience. Whenever an oncology drugs need to be included, there is a process of review and have an input from our oncology pharmacist. We have an oncology pharmacist. She is a board certified, and I think she is the second female pharmacist who got the board certification in Pakistan. So we took her also the input, but there are members from oncology services in the pharmacy and therapeutic committee, a physician that can back on that aspect. But as far as the evaluation of drug, the criterias are very standard as far as the joint commission is concerned. So whenever you are selecting any drugs, there are 4 5 6 parameters that you need to follow, and if those things are coming on that aspect, uh, that might not require that technical points which you were just mentioning about. But having said this, we have a certified board certified oncology pharmacist also, and we need their help also in the drug evaluation monographs. The point of pharmacoeconomics you just mentioned about, there are few individuals, because pharmacoeconomics is not a subspecialty in any of the teaching universities of the Pakistan. So we don't have we have a very simple MPhil, PhD, PharmD, and PhD. And very recently, certain universities included pharmacy practice as a fifth subspecialty in their curriculum. So there are universities like Aga Khan University Hospital has a collaboration with multiple international University of Waterloo, University of McGill, University of Johns Hopkins. So maybe in the future, as you just mentioned about, we can include the pharmacoeconomic expert based on availability on that aspect. One thing I just wanted to add on, if you allow me,
Sure.
is that the first time the Aga Khan University Hospital Karachi is seriously working on the specialty of the radiopharmaceuticals, because as the definition of the medications, all the radioisotopes and the radiopharmaceuticals are in the hands of the physician, like in the cath lab or in the cardiopulmonary and in radiology. But we are very fortunate that in Aga Khan Hospital, Nairobi, they have hired a pharmacist. Then they trained him, and he is now a consultant in terms of radio pharmaceuticals. And sooner or later, we will start this process in Karachi, Aga Khan, and then hopefully that model can be worked out in many parts of the Pakistan, as a new specialty and emerging field of the hospital pharmacy. Thank you.
Thank you so much, Dr. Shamim. Now, can we move to Shifa International Hospital? Dr. Salah, is she here?
Assalamu alaikum. Can you hear me all?
Yes, we can hear you.
Okay, so thank you very much for inviting me. I'll be sharing some of the key experiences that we had in establishing our PNT committee at the Shifa International Hospital. Well, I joined Shifa in 2016, and at that time, Shifa was not a Joint Commission International Accredited Organization. So obviously, you can well imagine the state of PNT committee at that time, and it is not wrong to say that that was pretty much dormant and not very active in terms of overseeing the medication management and use within the hospital. So the first task at hand was to convince the people around the senior leadership and the stakeholders that PNT committee is the backbone for any medication management oversight in the hospital. So the first task everybody should join hands in doing is to formalize a fully functional and fully active P&T committee. So for that, obviously, we had a target of acquiring Joint Commission International Accreditation very soon. So that actually fueled up the passion, and the senior leadership was also fully engaged in the conversation and gave the pharmacy the total free hand in the establishment and upgradation of the current P&T structure. So what we did actually is that the couple of things that really, were at the baseline that had to be improved is, first of all, the structure and format of the P&T committee. And the terms of references, because they were very vaguely defined. And to me, that was first task at hand, to define the scope and the terms of references for the P&T committee, including all the oversight, advisory, and monitoring and surveillance related roles of the P&T committee into that scope, so that all the stakeholders and the senior leadership approves that, endorses that, and then once that is endorsed, only then P&T committee can work within its scope without any hindrances or without any unnecessary interruptions into their active roles. So that was set. The second thing is was that we identified that there were no standing agendas. The P&T committee was only working merely as for the review of product additions, and that too was not very much based on the scientific basis. So the task at hand was to formalize all the standing agendas of the P&T committee, and that included, first of all, the addition and deletion of the formulary products based upon a scientific criteria. So once we set scientific criteria, then obviously we had to develop the selection criteria, the reference that we had to choose, the development of drug evaluation monographs, the class evaluation, how will it be performed, who will be performing it, how the product selection will take place. And once generic is included in the formulary, how we are going to select a brand out of tens of or hundreds of different brands available out there for that particular generic. So the extension of clinical review for a particular generic addition was also connected to the brand selection as well. So that was also developed as a scientific criteria of brand selection in terms of its company's stature, the good manufacturing practices. Now, we also conducted supply chain risk assessments in order to shortlist the companies to be included. We also developed, the selection criteria based upon the source of active pharmaceutical ingredient, how they are manufacturing it, any quality, special quality assurance strategies that they are taking for their brands, any the bioequivalence or biosimilar studies have been conducted for those products. So these kind of scientific criteria were also developed not only for the addition of generic, but also for the selection of the brand. And all these scientific criteria and selection process was backed up by a proper policy that was endorsed by the hospital leadership. Then another step or another challenge that we faced was that the composition of the P&T committee. Just like Dr. Tahir suggested and Dr. Shamim also suggested, that P&T committee must be relevant and must be representative of all the key clinical specialties. Just to name a few, for example, there should be critical care, there should be anesthesia, somebody from the OR side, emergency medicine, surgery, gynae, pediatrics, and special areas like specialty areas that when I say that, it means that the transplant, the oncology, and other similar kind of the specialty areas within the hospital. So here the medication management is pretty complex. So if they are on board as a member of P&T committee, they can act really as a good advocate for the overall group, and then they can take the message back to their departments and help in implementing the strategies, the policies, and the protocols that P&T are developing for their use. So that was the next step. So we upgraded the composition of P&T committee. In our PNT right now, we have all these major clinical specialties. We have nursing representation. We have quality department representation. We have senior leadership from medical staff representation. We have our 4 pharmacists, including myself, as a member of PNT committee. And obviously, the standing agendas include not only the addition and deletion of the formulary, but the medication safety related aspects, any safety advisories, adverse drug reactions, adverse events, near miss reports, any non-availability or shortages alerts. So these are agendas on every PNT committee meeting. So these are discussed, and then strategies are taken on accordingly. Another important thing is that lots of involvement or evolution of PNT committee took place during COVID pandemic, because we have to quickly respond to the changing needs and emerging data. So PNT committee developed lots of guidelines like remdesivir, Actemra, favipiravir, use of anticoagulation in the COVID, use of antibiotics or misuse of antibiotics in COVID, restricting issuance and prescribing privileges of azithromycin, ivermectin, hydroxychloroquine that were not relevant to COVID treatment. So if PNT would not have done this, there could be a disaster in terms of misuse of these particular drugs, and then restricting dispensing and prescribing privileges of certain drugs when we were hit hardly by some outages of important drugs like dexamethasone and methylprednisolone in the initial days of the COVID. So that was the major role of PNT committee. In SHIFA, we have a subcommittee of PNT committee, which is antibiotic stewardship subcommittee, and it is headed by ID expert, and ID pharmacists are part of it, and representation again from the key clinical areas and nursing side. Another important thing is that our pharmacy also gives oversight to our external hospitals. One is situated in Faisalabad, and one is dealing with the foundation, which is the welfare organization for the managed under the Shifa Medical College, and it has a separate hospital clinic setup and its own PNT committee. So our main campus PNT also gives oversight to these 2 areas. So a lot of challenges. So I'll just sum up by saying that without PNT committee, without its oversight, obviously the medication management and the medication safety related aspects cannot be brought together, and there will always be lacunas, there will always be pitfalls which can actually lead to the harm towards the patient, and loss on account of financial loss or reputational loss on account of hospital if the medications are not or poorly managed. So PNT committee has to be there in a fully functional form. Thank you so much. So if any questions are there.
Thank you so much, Dr. Salwa. Great presentation, and you have a great pharmacy and therapeutic committee. I think I visited your hospital a couple of years ago in Islamabad, and I have seen the pharmacy. It's really great pharmacy services there. We have the same question here, because all these hospitals are in private sectors, are non-profit organization. Like Shogat Khanam is a non-profit organization. Shifa is also trust. Khan University Hospital is also trust hospital. So private slash non-profit organization. Can we replicate these experiences in the government sector? But before that, I want to ask Dr. Shireen and all the panelists and all the members, any question for Dr. Salwa?
Yes, I have a small question. Thank you, Dr. Salwa, for sharing the experience at Shifa Hospital. So pretty much the structure, like you have like a very well structured infrastructure, I would say, for the PNT. So I was wondering about the other subcommittees. You mentioned that you have an antimicrobial stewardship subcommittee. So are you having another dedicated committee that looks at the drug evaluation? You mentioned that you have a criteria, but do you have a dedicated personnel who work on that and report to the PNT, or you assign the evaluation to individual clinical pharmacists?
Well, we have a team of 6 clinical pharmacists, and they are providing all the backup to the PNT committee in terms of drug evaluation, ADR monitoring, ADR tracking, pharmacovigilance activities, post-addition reviews, DURs, all those kind of activities for the PNT and its subcommittee are being performed by these 6 clinical pharmacists. So this team actually, any request comes in, they will develop the drug evaluation or the class evaluation, and they will be presenting it to the PNT committee. So currently we don't have a separate committee on this score. The agenda comes in the main PNT directly.
Okay, interesting. But the evaluation is done by the clinical pharmacist. That's the assuring thing. Okay, that's great. Yeah.
Thank you, Dr. Silva. Thank you, Dr. Silva, for a great presentation. Because of time constraint, actually, we started a little bit late, so we are behind schedule. But the thing that I was discussing, that we have great experience in 3 hospitals, Shaukat Khanum Cancer Hospital, which is a corporate organization, and then Khan University Hospital in Karachi and Shifa National Hospitals. So there is a very good structure of pharmacy and therapeutic committee exists there. Can we replicate this in the public sector, in the government sector? And for that, we would like to hear the last panelist, Dr. Zahid, please.
Assalamu alaikum, and thank you so much for having me. Am I audible? Thank you.
Yes.
So before I start, I'd like to tell about the background of Ministry of Health. Where it started from, I have collected little data. I apologize if I miss anything. Little to my knowledge. Well, after the 18th Amendment, the Ministry of Health was devolved and the powers were given to the provincial governments. And later on, the draft came into being in 2012, and under its pharmacy division, under Dr. Abdul Rashid, many of the notifications have been launched for the establishment of the pharmacy services in the public sector hospitals of all of the provinces. And obviously, the pharmacy services establishment contains Pharmacy and Therapeutics Committee, which is a big chapter. It also wrote about the National Action Plan for combating the antimicrobial resistance. And lastly, the latest notification that the draft has issued is about the integration of the clinical pharmacists in the healthcare system, which was launched on 26th of July 2021. Representing the Punjab government, I've been working there for 2 years. In 2014, the Punjab Health Department formulated essential medicine list by the consultation of the provincial medical stakeholders and US state, which was further endorsed by WHO for the primary and secondary healthcare department. The Punjab Healthcare Department is bifurcated into 2 disciplines. The one is primary and secondary healthcare department. The other one is specialized in tertiary care hospitals, which almost have around 150 hospitals throughout the province. Moving on to that, in 2018, the Punjab Medicine Formulary was established, which was a torch-bearing guideline for the procurement of the safe and reputable drug brands in the hospitals in the Punjab. The ideal and the main concept about the formulary is, for example, we talk about the British National Formulary. It gives us about the clinical guidelines, the usage and the areas, everything like that. But looking at the safety and efficacy, the Punjab government chose to develop the list of the reputable, verified, tested brands to give a guideline to all of the government hospitals for the procurement of the safer drugs at first. After the notifications from the draft, the pharmacy services, it issued a notification for the establishment of Pharmacy and Therapeutics Committee, and that has been implemented in almost 90% of the hospitals in Punjab, both in primary and secondary care hospitals, as well as the specialized ones. They have given different designations to the pharmacists who have they hired. The one is pharmacy manager. Under his command, the other pharmacists are working. The second designation they allotted was clinical pharmacists and pharmacovigilance officers, who will be creating subcommittees under Pharmacy and Therapeutics Committee, that is Pharmacovigilance Subcommittee. And then the hospital drug inspector for taking the samples of the procured drugs, because it is in the public sector, the drugs are procured on the annual contract basis. So once you get the drugs, you have the whole supply for the year. So in order to keep it in line with all the storage practices and to be sure the drugs are of the same quality, the drug inspectors, before the usage of the drugs, take samples and give the verification letter to the administration, these are to be used by the hospital. Regarding the provision of the hospital pharmacy services, notified pharmacy managers have been assigned the TORs, in which the government made some brief guidelines that the chief pharmacist will be the secretary of the Pharmacy and Therapeutics Committee. The Pharmacy and Therapeutics Committee will develop the formulary and put up before the Pharmacy and Therapeutics Committee for the evaluation and approval. Chief pharmacist will design different policies regarding rational use of drugs, medicine, regulatory strategies, and put up before the PNTC approval. Chief pharmacist will develop coordination and cooperation among other healthcare professionals, and he will establish the telepharmacy services in secondary and tertiary care set up to deliver essential medicines for chronic usage. A minimum of 3 pharmacists, including pharmacy manager, drug inspector, and clinical pharmacist, will be the members of the PNTC. That was a structure given by the policies from the Punjab government, and that has been established, and around consequently above said committees have been established by the notified pharmacy managers in 101 facilities, and meetings are being conducted by the pharmacists whose minutes are being recorded and shared with the department when required. As Punjab is the biggest province of Pakistan, having almost 110 million population, moving on to the next, Sindh, which has almost 47 million population, has not issued any provincial guidelines for the development of the pharmacy services yet, to my knowledge. But if you look at the privatization of the hospitals or the employment of the medical specialists by the government institutes, which has now begun, I would like to mention a few names which are doing very good in terms of establishing pharmacy services and PNTC committee. That is NICVD Hospital in Sindh, especially Karachi, and Tabahad Institute, Dow Institute, etc. Moving on to the third big province, Khyber Pakhtunkhwa, having 35 million population. Once again, because of the poor legislation and authorities, they haven't issued any guidelines for the establishment of pharmacy services. One institute after the privatization, I would like to mention, is Lady Reading Hospital has hired a pharmacy specialist as a pharmacy manager, and they have developed a very good pharmacy system in the sector, which is having almost 1,700 beds, and they have established pharmacy and therapeutics committee, and recently they started the antimicrobial stewardship program there. Last but not the least, the Balochistan, having 12 million population, yet is the biggest province in terms of area, but in terms of population, it is the smallest province of Pakistan. Their pharmacy department and directorate haven't established or haven't launched any pharmacy services notification. And the pharmacists are mainly involved in the procurement of the drugs, since it is the biggest chapters. The MBBS department or the administrations of the hospitals, they ask the pharmacists to be involved in the procurement of the drugs than to be in the clinical aspects. They don't know about the pharmacy and therapeutics committees. It is we who have to establish, thanks to the Punjab government for employing almost 500 pharmacists, and they're again creating vacancies for integration of the clinical pharmacists by creating a draft. And I'm very honored that our section officer, Hospital Pharmacy Punjab, is among the listeners, and she would be happy to know that Punjab is doing well with that regard. Thank you so much. That was all from my side.
Thank you so much, Dr. Zahid. I think we are running behind the schedule. We spent like 15 minutes time more, and Dr. Shaheen needs to take the breakfast. So we can wrap it up like in next couple of minutes. So I think what we have learned today from this workshop, that we have a very good pharmacy and therapeutic structures in some hospitals, in public, in private sector and non-profit organizations, particularly private sector, I would say. We don't have good structure of pharmacy and therapeutic committee in the Ministry of Health or in the government sector. Yes, I think one of the things that we have, why the pharmacy and therapeutic committee structure is existing in the private sector or in non-profit organization sense, because they have very good pharmacy residency program. The Shaukat Khanum Cancer Hospital has a very good pharmacy residency program, which is ASHP accredited. And most of the time, our drugs are evaluated by clinical pharmacists, which are trained from these residency program. We are even supervising the residents for evaluation of these drugs in the PNT committee, workflow. And Aachen University Hospital has very good residency program. They're trying to go for ASHP accreditation, and Shifa International Hospital in Islamabad is having very good residency program. They have some loopholes, but they are trying to seek for ASHP accreditation. Now, we discussed yesterday with our health minister in yesterday opening ceremony, can we replicate the experience of these private sectors in the government sectors? So he extended his full support and assurances. Now, we need to step up. We need to step up forward and meet with the stakeholders, health ministry, the minister of the health, and other stakeholders in the province and in the federal government. First of all, train our pharmacists. One of the challenge that we have, we don't have competent clinical pharmacists to run the show of the Pharmacy and Therapeutic Committee. It's not only PNT committee, it's not only formulary management, as Dr. Sarbo was talking about, it's the composition, it's composed of so many other elements. So we really need to have good clinical pharmacists. And unfortunately, we discussed this with the previous provincial chief minister. Like he was super enthusiastic to start this pharmacy residency program, but unfortunately, we don't have good mentors and preceptors in the Ministry of Health who can actually provide education to our residents. We have the residents, we have the seats for the residency in the provincial government, for example, but we don't have people to train them. So I think that the challenges that we have is the lack of competency of the clinical pharmacists. We need to work on that. For that, we need to meet with the stakeholders and societies and the regulatory bodies. And then we need to improve our structure of the PNT committee, even in the private sector that we went through. Like, for example, we don't have pharmacoeconomic structure, which is the part and pillar of the Pharmacy and Therapeutic Committee, and we don't have that in any hospitals in Pakistan. So I think we need to work on that. We need to improve on the composition of the Pharmacy and Therapeutic Committee. It should be balanced between physician and pharmacy. So so that we have like 50% of the committee members. I mean, we do have members from the logistics. We do have the members, not from the finance, from the pharmacoeconomic center. We should have them. But the number of the physicians, the number of the pharmacists, clinical pharmacists should be balanced with the proportion. And they should have equal and same amount of the voice. And in terms of the voting, they should have the same, the weightage in terms of the voting as the physician has. So that's the purpose of the Pharmacy and Therapeutic Committee. So we need to work on a lot of areas. Private sector is already there, it's shining, but we need to work a lot in the government sector. I would like to hear from Dr. Tahir Aziz to conclude, to give his concluding remarks in 1-2 minutes.
Yeah, thank you very much, Mansoor. I think I totally agree with Mansoor. Obviously, as earlier I said, this is not an easy step, but this is very doable and we can easily do within a stepwise manner. And I agree, even as our minister has already been, told yesterday, he committed very well. He agreed that they are working on and they are devising a new framework and they are working on the draft act as well. And I hope some of the problem we are facing right now at the level of government, I hope this should be fixed soon. So soon we have to, I hope this will be a ice break, movement on that once we have a new act in a motion within next few months. And I totally agree. The major problem we are facing is the technical and the competent staff. And this is a major area, and I believe that going back to pharmacy in Pakistan can play a major role. And we all have to think, how can we improve, the competency, how can we improve or develop a good clinical pharmacist by, doing or starting a residency program. And obviously, how can we strengthen the pharmacy? Because once we have a good pharmacy setup, then we can move forward to develop a good pharmacy and therapeutic committee within these hospitals. So initial step again is the foundation, is a good foundation of the pharmacy setup. So let's see, hope for the best. Thank you very much.
Thank you, Dr. Tahir. Dr. Shireen, 1 minute, your conclusive remarks about Pakistan PNT structure.
Well, it seems that, what I've heard from the discussions from various panelists about the introduction of pharmacy residency program, and I think that or PGY2 accreditations through the American Society of Healthcare Pharmacists, I think that's one of the things that we can always invest on in terms of human resources and having high quality pharmacists, the clinical pharmacists doing drug evaluations. and those can definitely be mentored by expertise, and they can help a lot in terms of like cutting down the the long list, waited list of drug evaluations, because it's kind of going to be done with them. So that's one thing, just to overcome the human factor in case that's something. So we have to invest in this. And the other thing is that perhaps at the public sector, maybe investing more on conducting like workshop to enhance the educations of the pharmacists and their awareness about the importance and of their role and engagement in the pharmacy and therapeutic committee, enhancing their clinical evidence-based skills and interpretation of the literature, so they can perform at best when they serve as members of the P&T committee. That's what I can say. Yeah.
Thanks, Dr. Shireen. Any other panelists would like to conclude within 1 minute? We would like to say thanks to all the audience, all the panelists, organizing committee members, scientific committee members for putting great effort to run this the Pharmacy and Therapeutic Committee workshop. And I was suggesting that we can move forward and write a review article about experience from this workshop and publish in Pharmacy and Therapeutic Committee Journal. And I think the whole thing that we discussed today, we can summarize it and we can conclude like how can we improve the Pharmacy and Therapeutic Committee structure in Pakistan. If there is no question, no comment, then we can conclude the whole Pharmacy and Therapeutic Committee workshop. If there is no question. So I think there is no more questions, so we can conclude this Pharmacy and Therapeutic Committee workshop. Thank you, everyone, all the panelists, all the organizing committee members for putting great effort. Thank you so much. Assalamu alaikum.
Thank you so much for the invitation, Dr. Mansoor, and all the.
Dr. Shireen, you can go and take your breakfast. Go and take your breakfast.
Okay, thank you.
For taking you longer. Thank you so much for joining us.
Thank you.
So much.
Thank you for the invitation. It's been nice to be with you today. Thank you. Assalamu alaikum.
Just want to have a short break now, and we will start our hospital and informatics track session starting 8 p.m. Pakistan time. So stay tuned after this short break. Thank you very much.
Thank you. Assalamu alaikum.
Assalamu alaikum.